Good evening, friends. It is a pride and privilege for me to convene yet another important academic activity of the Indian Association of Gastrointestinal Endoscopic Surgeons. We are happy to have you this evening for the IAGES Primetime program, which happens twice a month. I thank the advisors, trustees, and the president, Dr. Aman Goel, for bestowing me upon this opportunity to convene this program. Now, we have two important personalities contributing for this evening IAGES prime time. One is an international minimally invasive surgery exponent, Professor David Lomanto, being interviewed by our senior member and the trustee of the IAGES, past president, Dr. Ramesh Agarwalla, followed by an most eminent minimally invasive surgery personality of India, none other than Professor M.C. Mishra, being ably interviewed by Professor Sandeep Agarwal, who is a professor of surgery at All India Institute of Medical Sciences. So with that few words, now I would like to call the meeting into order, and it is my pride and privilege to call upon Dr. Ramesh Agarwalla sir to warmly introduce Dr. David Lomanto. As a matter of privilege, I take pride in introducing Dr. Ramesh Agarwalla. Dr. Ramesh Agarwalla is the director of the Department of GI and Minimal Invasive Surgery at the Fortis Hospital, Kolkata. He has more than 3.5 decades of minimal invasive surgery experience and a whopping 25,000 laparoscopic surgeries to his credit. He is well versed in both advanced and common procedures. In fact, he is a specialist in complex abdominal surgeries and an expert in colon and rectal resections. He is an exponent of laparoscopic hernia repair, laparoscopic GI oncology surgeries, and in fact, he also does a lot of advanced solid organ surgeries, inclusive of bariatric and metabolic surgeries. He was the president of the Indian Association of Gastrointestinal Endosurgeons 2016 and 17, and has the very important achievement of recruiting most number of new members and maximum number of academic initiatives during his term. And he is the current president of the Hernia Society of India and the National Chapter of Asia Pacific Hernia Society. He was the past governing council member of the ASI, secretary of the alumni of Royal College of Surgeons of Edinburgh, and executive member of the ASI West Bengal. He was the past secretary of the Indian Association of Surgical Gastroenterology, and he is the tutor and guide for the National Board of Examinations in General Surgery and Surgical Gastroenterology, and he is an overseas tutor and examiner for Royal College of Surgeons of Edinburgh. At this point of time, he also chairs very important responsibilities of IAGES, and he is also hosting the World Conference of the Laparoscopic Surgeons in India in 2024. And I also am happy to announce he is the chairman of the research committee of the IAGES, which oversees important research initiatives of the IAGES apart from many other contributions. Ladies and gentlemen, now I have the honor of inviting Dr. Ramesh Agarwalla to start the evening's proceedings. Over to you, Dr. Ramesh Agarwalla.
Thank you, Dr. Kanabel. I really feel very humbled by your such a generous introduction. I'm very happy to be a part of this prime time initiative of IAGES, which has been initiated by our president, Dr. Aman Goel. It's a matter of pride and privilege to introduce my longtime friend, Professor David Lomanto, who graduated from magna cum laude in medicine and surgery in 1983 from La Sapienza, University of Rome, Italy. He completed general surgical training in 1992. Prior to that, he did his PhD in gastrointestinal surgery in 1990 at the same university. Currently, he is the professor of surgery at National University of Singapore. He is the director of Minimally Invasive Surgical Center, National University Hospital. He's the director, KTP Advanced Surgical Training Center, NUS. He's the Secretary General and the past president of endoscopic in 1990 surgeons at the same university, ELSA, and the founding member and advisory president, Asia Pacific Hernia Society. He's also the founding member and the past president of Asia Pacific Metabolic and Bariatric Surgery Society. He is the president of Asia Endoscopic Task Force. He is the Secretary General and Treasurer of International Federation of Societies of Endoscopic Surgeons, which is also known as IFSIS. He has more than 150 publications in international peer-reviewed surgical journals, and he's written more than 25 chapters in surgical books. He's the editor of 6 surgical books. He's been awarded numerous honorary memberships, which include the Royal College of Surgeons of Edinburgh, the Endo-Laparoscopic Surgery Societies of Japan, IAGES from India, the societies from Indonesia, Philippines, Thailand. He serves as the managing editor of Asian Journal of Endoscopic Surgery. He's the associated editor of Hernia Journal and international editorial member of Surgical Endoscopy and Asian Journal of Surgery. He was bestowed the knighthood by the Italian government on 26 December 2009. Ladies and gentlemen, it's my proud privilege to present to you Professor David Lomanto, one of the legends of surgery, to you.
Raman, you would like to say a few words? Sir, you are in mute mode, sir. Lot of lights behind you.
I'll join in later. You please go ahead.
Perfect, sir. Perfect. So thank you, Dr. Ramesh Agarwalla, for the kind introduction. Now we'll listen to Dr. David Lomanto.
I'm David Lomanto from Singapore, and I'm very honored to be part of the IAGES Primes, this new program that under the leadership of the President of IAGES, Dr. Ramesh, I think started one or two couple of weeks ago, and I've had the honor to participate. I will share with you in the next probably minutes my experience on the ventral area, about 20 years of experience, what I learned, how I changed my clinical practice, and so on. Let me share the screen with you. I prepared a bit of slides, and just to, as a guideline on some thought about repair of hernia. An update on a two-day approach on a very old problem. A problem that was for a long time not unresolved, but have poor outcome because the difficulty, the challenge, and the technology that was not the correct one. So now we have a better picture, and you can see during my presentation how the evolution in the last 2 decades I come up with the new approaches. I think we can talk about, when we talk about hernia, I think that one of the men that really changed all was, first of all, Bassini a long time ago, and subsequently Irving Liechtenstein, because we moved from the concept of tension towards the concept of tension-free, because it was the cause of failure or the cause of the poor outcome postoperative. And this was widely applied to any type of hernia, from hiatal hernia to inguinal hernia to ventral hernia. Irving Liechtenstein also applied, was talking about tension-free repair for inguinal hernia. And patching, actually, versus suture was the main problem. But we need to understand that the abdominal wall, as we know today, more than 20 years ago, is a proper organ, a very own physiopathology, And he has written about movement, about strengthening, about supporting the spine, about coughing, about constipation, defecation, and a lot of other function other than protecting the organ inside the abdominal cavity. That's why the surgical option for mesh repair in terms of patching was mostly in the past only two methods, onlay and inlay. Then Reeve Sopa start to talk about the retromuscular repair. And the evolution was only later in the early 2000 when laparoscopic started. So we start to talk about the IPOM. So the intraperitoneal onlay mesh, even though it's not a really good term because intraperitoneal and then onlay mesh. But since the 2000, you can see, since the IPOM appeared, we have evolved so much with the IPOM Plus, with the preperitoneal onlay mesh, a kind of TAPP, and then the transabdominal partially extraperitoneal, the extended TP, and the Milos with a minimal invasive approach to the abdominal retromuscular repair, and also the utilization more of muscle release to reduce the tension that can be created by the mesh, the position of the mesh or the closure of the wall. So we will talk about bridging, augmentation, and to make it simple, I think probably the TAR and the Botox and the component separation just try to improve what is the mostly the augmentation more than bridging. And also there was an evolution toward the mesh position in the last 20 years from the, of course, onlay was still common because a simple technique, but with a very, very poor outcome, as many studies show, but from the intraperitoneal mesh placement towards more an extraperitoneal mesh. This was a kind of evolution, more than a revolution. So I started with IPOM early 2000 when soon the mesh, the so-called coated or gore base actually were in the market, and but only in the last 15 years I did about more than 1,250 patients, and you can see how the patients have become more complex from the initial 10%, 8%, now we are doing more than 20-25% of complex hernia. And also in the, I must say, the latest year, we start to understand more about the rectus diastasis associated with the ventral hernia, because it was mostly a cause of failure. So we see how there was a kind of evolution towards a better understanding of the physiopathology of the repair itself. You can see, of course, female are more in our group, mostly because incisional hernia being one of the especially complication, long-term complication of cesarean section are mostly, you can see 58% in the female patient group. So I learned something case by case, from case 1 to case 100 to 300 to 500 to 1,000 and so on. And why? I learned that hernia is not like a simple hole. So we need to understand more about the patient. We need to understand more about the symptoms. We need to look at the patient, his risk factor, the comorbidity, the location of the hernia itself, the condition of the soft tissue, if the patient is an old patient, if the muscles are very weak, the abdominal wall is very weak, if the muscles are far apart. So we need to understand more to kind of tailor a better repair. And in terms of optimization pre-op, in terms of the comorbidity, I think diabetes play a very big roles. Same as the smoking, so we should push the patient to stop 4 weeks before the surgery, and obesity. Today, obesity is a very important problem, And today we know that if the patient is have a BMI more than 30, the complication and the outcome is very poor, with an increased risk of 5 times more compared below 27, 28 BMI. Intra-abdominal pressure is higher, the soft tissue is less perfused. There is a lot of issues. Other cofactors are important, but much less important than those 3, like diabetes, smoking, and obesity. Then we also need to look at the expertise that we acquire at the hospital facility, the experience, the skill set that we have. Because a key factor for a successful repair is not a simple patching, because it doesn't work, but we need to restore the abdominal wall continuity. We need to restore the functionality of the abdominal wall. We need to recreate the linea alba by primary closure, preserve the blood supply, and provide a repair that long-lasting with the minimum tension. These are the key factors for a successful repair. So an adequate preoperative workout is very important, with the CT scan, CT reconstruction, especially in a recurrent case, in the case in which a primary repair already failed, and also a timeline to repair the patient, but also the post-operative play a very important role in terms of recovery and rehabilitation. So from case 1, we always start simple, easy. Cases like this that even though are the more common, but sometimes are the most challenging. And in this case, I always use a mesh. Why? Because hernia is a metabolic defect. So the primary Mayo repair that we usually do for small defect, and I still do for small defect, it doesn't work. We have a recurrence that goes up to 40%. So we need to understand that hernia as a metabolic defect carry a collagen defect, carry a deficiency of nutritional factor. He has a wound healing failure after laparotomy because there is a fascia pathology that instead of creating normal scar tissue, create a disorganized scar tissue that lead to the formation of incisional hernia. While for recurrent hernia is a combination of both tissue disorder, wound healing failure, and collagen or MPX defect. So when we consider this one, we do understand that the suture repair may fail in 30–40% because there is underlying metabolic defect. So we almost use a patch, even for ventral hernia, simple. We seldom do laparoscopic. You can see in the fast forward movie how the small umbilical hernia is isolated, is reduced, and then the peritoneum open, and then we have this kind of parachute that is coated mesh. We can put in the pre-peritoneal space or in the intra-peritoneal space a kind of open IPOM. So I mostly prefer in the pre-peritoneal space because it's extra-peritoneal, and then we just fix the mesh and we close the fascia. So it's a Mayo plus. When we progress further to 30–50 cases, I think we can move towards more difficult case in which we need to do a more challenging. We can do laparoscopic, in which there are already previous surgery. So adhesion, intraoperative adhesion may be a challenge. So we acquire more. And in this case, we always prefer a posterior repair. We seldom do only repair. And you can choose, in case like this, you can do a IPOM, IPOM plus, ETP, TAPP, PPOM, anything you like, but put the mesh posterior. I strongly believe that IPOM is still, in majority of cases, a good approach. It's effective. Mesh technology today is not that bad, improve a lot. We still have probably adhesion, but adhesion and that are requiring reoperation may happen probably less than 1% of the patients. So still a good repair IPOM, and probably still the technique that has more case, more evidence base in the primary hernia and incisional hernia for laparoscopic approach. But IPOM, I think, evolved too. Why? Because more than the bridging and patching, today we move towards an IPOM plus. So we close the defect. Why? Because we want to have less weakening point behind the mesh. We want to avoid the patient as a pseudo recurrence. In patient like with this bulge, a big abdomen, we need to bring the muscle together, and we can close the defect through a transfascial suture, through intracorporeal suture, like in the video, using, for example, VLOC that help you a lot, or combine it. Why? Linea alba must be closed because it's a support for the spine, for respiration, for defecation. This is how we do our LARDA technique, laparoscopic assisted repair of the rectus diastasis, and we use a transfascial suture approximating the bone muscle. Why IPOM plus? Because all the studies show that there is a reduced rate of seroma, of adverse side effect, and also recurrence. You can see the recurrence rate is much, in the closure defect, is much lower compared to 16, 17, higher in the other cases. Even though the latest guideline that we published last year with the IAGES, we know that the primary goal is the reconstruction of the linea alba to give back a functionality to the abdominal wall, and the IPOM plus result in less recurrence, seroma and bulging as a level 2C compared to non-closure repair. So this case, we need to have this kind of results. That's our aim. But what are the problems? The problem with IPOM, as everybody say, is the adhesion, bowel injury. Sometimes the meshing growth is not that good, especially when you use a microporous like a gore. Pain, bulging, seroma, and also the cost, especially in developing country, the mesh, the coated mesh and tacker are huge costs that not many patients can afford. That's why Reinhold in Germany started to propose a mini or less open sublay operation that have a minimally invasive approach. You can see with a small incision periumbilical and then preparation of the retromuscular plane with the combined technique that goes between mini open and laparoscopy. First report on analysis surgery last year of about 600 cases comparing with IPOM show fewer postoperative complication, general complication, less recurrent, less pain. As usually, I am in favor of always not the superiority, but non-superiority. So equal technique. We need to prove the technique works, and there's no one technique better than the other one, or one technique can solve all the problems. So this is very important. So when we progress further, we have more referral, and then we start to have case like this, case with large, multiple defect, multiple failure of previous repair. Or we have patients that come up to us with the lateral hernia or suprapubic hernia, like a most Phanestin, or parastomal hernia, or subcostal hernia, like these cases after liver transplant or liver surgery, or a case like in this, which is a lateral hernia or post orthopedic operation. And we just published our series on a tailored approach as a hernia center for lateral ventral hernia, one of the largest series, about more than 23 cases. So you can see how in this case we have different options also. We have an option that, as in this case of lateral hernia, goes with the transabdominal preperitoneal repair, a classical TAPP in which we do a flap, and the flap must be done at least 10 centimeters apart from the edge, from the closer edge of the hernia defect. So we enter the avascular plane, the preperitoneal plane, and you can see the rectus muscle, the transversus abdominis, and we isolate all the tissue around the defect. You can see the defect here on top, and as any hernia, also in this case, we approximate the defect using the suture. In this case, we use transversal suture. Important that you don't tight too much the transversal suture, just to approximate, loose. So in this way, you can reduce the pain. And then we just put a normal polypropylene mesh. This is a very good technique, especially in India, where there is a lot of people using a polypropylene mesh in IPOM. I think switching to this technique, it will give you a better. Then you close the flap so the mesh is completely outside the abdomen. In some cases, like a lateral flank hernia, like the one before, we also use an extended TP. In a means, it's a retromuscular repair. We go directly in the retromuscular space. Most of the patients that we did before and this one are referral from after orthopedic. Probably they do spine approach, the injury, they don't close, or some wound infection, and then there is a rupture of the fascia, and there's this lateral hernia. In this case, you can see we enter directly the retroperitoneal space. Patient is in lateral decubitus, and we just go behind either the rectus muscle or the internal oblique, and then we enter the space, the preperitoneal space, and then we isolate the hernia. You will see soon. So same at the PPO, preperitoneal or TAPP, but with a different approach, with a completely extraperitoneal repair, in a kind of retromuscular repair. We can call it TP, we can call as we like. Anyway, it's a typical ripstop repair in which we go in the preperitoneal. You can see the hernia defect. In this case, you can see identify the defect. We need to clear at least 5-6 centimeters all around. In this case, we use intracorporeal suturing with the V-lock, non-absorbable, 15 cm. You can reduce a bit the pressure to reduce the space and to reduce the tension. Sometimes I put extracorporeal suture to approximate, and then I remove the suture. This help me to bring the edge of together. And then I use in this case we use a ProGrip mesh, and then we just desufflate after overlapping. The defect is closed. We just desufflate with a nice result. So we do this case also, for example, for combined Spigelian, bilateral Spigelian, and right inguinal hernia. This is probably the proper ETP, because it's a TP for bilateral, but then we extend laterally and up to close, to reduce the Spigelian hernia, like in this case, Spigelian hernia. Sometimes Spigelian hernia is visible, but it's very difficult to identify. But it is important that we go directly at the intermuscular space, the Spigelian area, and then see in this case we close also the peritoneum, and then the hernia is on top, and then we use a mesh to overlap and closing the defect. We use 3 mesh, one for the Spigelian, one for the 2 for the inguinal. In case of suprapubic hernia, that's the most challenge. We always use a TAP, trans-abdominal partial extraperitoneal. Why? Because sometimes it's not that easy to go complete extraperitoneal, because if the patient has a multiple repair or multiple surgery, there's a lot of scar tissue. Sometimes there's even no subcutaneous fat, because the peritoneum is attached to the skin. So that's why in this case we do a diagnostic flap, we do a big flap like a TAPP, and then we anchoring the mesh to the Cooper ligament bilaterally, and we cover the defect on top. We cover the mesh partially with the mesh. We cover the defect. You can see the mesh is partially extraperitoneal when we close the flap. When we close the flap. This is another case. You can see multiple hernia here. You can see multiple hernia, 1 and 2. So we do always a peritoneal repair, a flap, a peritoneal flap, and then we go in the preperitoneal space. What are the challenge? The challenge for extraperitoneal repair, it is possible there is if a single hernia, primary, midline is a very simple repair. But if the hernia is a recurrent, a previous repair has been done, maybe a previous open or multiple surgery, sometimes the extraperitoneal space is not that simple. So when you do multiple all in the peritoneum, there is a risk that we don't see below. So I always like to have a double view, intraperitoneal, extraperitoneal view. We need a lot of dexterity. We have a very poor ergonomics. Sometimes we need a very extensive dissection, and sometimes we need to suture in the, not in the poor ergonomic. That's why I started to use, especially for ventral hernia that are on the lateral side. When I use the extraperitoneal approach, I used to use the robot, because it gives me better dexterity, much more relaxing. I can still avoid the use of tacker. I can close most of the defect in 95% of the cases. So the cost is also cheaper, because I can use a simple polypropylene, no stapler, no tacker, with a better ergonomics. What is the evidence? For sure, it's better the open, but it's comparable to laparoscopic. If you see the cases are similar. So I think, why don't do the same laparoscopic but with a better ergonomic and using the robot if the cost is achievable? How we start? We start simple. You can see in this case, for example, we need to learn at the beginning. We start a simple, not IPOM, but we always do a preperitoneal repair. This is a midline hernia. Then we do a flap. We go, we can see, look at how it's easy to maneuver. This patient already got a umbilical repair with mesh onlay and failed. You can see there's a big diastasis of the muscle that we can close by intracorporeal suture with a much easier ergonomic. You know the difficulty that we have to suture when we are on the parallel way and on top, on the roof of the abdomen. With the robot, you can also swap and suture the top like a watching now. So it's much easier, and they give you much more room for improvement. We go faster. You can see how you can close with a very accurate maneuver. And then you can pull slowly until you close all down. So if you need to do a lot of suturing, a lot of dissection, I think robot will make your life much easier, more relaxing. You can see, so the construction of the linea alba is feasible. Yeah? The construction of the linea alba is feasible. Then we put a mesh and then we close the flap. And then it's the patient. You can see the patient after a few months. You can see how very good abdominal reconstruction and abdominal wall. We have patients that are also more dramatic, failure. Patient like this one, bottom right, in which I will show you the case in which you can see the ISIS has been harvested to reconstruct the mandible because of the tumor. And it's a very interesting case, has been referred to me from Europe. And you can see how there is a lack of there's a lack of anterior superior spine has been harvested, you can see, to reconstruct the muscle. So in case I did robotic, the choice, this patient already have one surgery for harvesting and 2 surgery for repair of the hernia, 1 suture and 1 mesh. So I want to be sure. So that's why I went intraperitoneally to have a good diagnostic. I can also go extraperitoneal at this point, but I just easily make a flap. I just easily make a flap. I can see the triangle of doom, the iliac crest that is missing completely. The colon is here, so in case I can have a wash, close on the colon. So I will mark the repair. I will mark the flap, and I can enter the extraperitoneal space. You can see the transversal down, and now we are entering the area that has been already touched 3 times for the harvesting, so a lot of scar tissue. You can see that the robot, we only use 2 instruments, the mega needle holder and the scissor. So that's also another advantage. We use only 2 arms, we don't need to use a 3rd arm. Only in selected case, we use a 3rd arm just for a bit of retraction, or you can just ask one of the assistants. So we are on top of the bone now, and then we go down to the bone. So you need to have articulation, you need to have a wrist movement, because you need to go behind the anterior iliac spine. So, and there's all scar tissue. So quite challenging to do with the straight instrument of laparoscopy. You can see here, the iliac crest, so we need to go behind the bone. And then of course you have a 3D that helps you a lot. So we have 12 centimeter defect, it's a longitudinal defect, so we did the plication. And we use a transfascial suture to approximate, as I explained you first. You can see I use transfascial suture to approximate the defect, and then I overrun with the running suture. This is also helped me to avoid a lot of tension during my suturing. In other case, you can still do by yourself. You can use a Botox, for example, to relax the muscle. Botox usually you do 4 weeks before. So then you use I use a Pro Grip, and in this case I use a permanent tacker. You can see titanium tacker on the bone. I am above the laterocutaneous genitofemoral nerve, so I'm quite safe. And then the nerve, in case it's in front, it's not on the bone side. So this is very important, the anchoring point here. And the patient now is already more than a year. And then you close the flap. So you can see the patient after 6 months is perfectly done. And then we have a few more cases. You can see these are inframuscular. You can see in the transversus, the external, internal oblique, external oblique, the area between the 2 oblique muscle. And in this case, same, we do the same kind of approach. I will not repeat. More about, see, I can teach. For example, this is my junior that is the case. I was asking him to suture, and I can draw, say, okay, look, you can draw here, you can suture here, and then you do. In this case, we did 3 plication of the muscle to close it. Then a large abdominal defect, case like this, complex because of the comorbidity like obesity. In this case, we use always a very tailored approach. How? We use both muscle relaxation. I prefer mostly all the time, if I can do, I do a Botox, and or I use a TAR. And most of the case, you can see I use under 50 unit each in each lateral muscle. 50 units on each side. So 50 units for the, for example, right oblique, external oblique, 50 units for the internal oblique, and 50 units for the transversus under ultrasound. And I do it 3 to 4 weeks before the surgery, because that's why the time it takes to relax, and I can gain 6-7 centimeters on both sides. And this, for example, a patient that was morbid obese, so we bring the BMI below 30. We don't do any surgery. We try to make, I do bariatric surgery, so we put them on very low calorie diet, and then this is how intraperitoneal looks. And then we do a combined approach in which we do a closure with a suture, primary suture, and then we did an excision of the skin because it was terrible. We don't go deeper, and then we do a mesh repair. It is very important that, remember, not only the surgical skill, our expertise is very important, but also the post-op require a proper approach. As I think everybody knows today, that we need to use abdominal binder for at least 4-6 weeks, avoid lifting up to 4-6 weeks too. We tend to mobilize the patient and to ask the patient to exercise, light exercise, because we want to have a very good muscle, because the muscle are the key for a successful. We don't keep the patient at rest for so long, otherwise the muscle become weak, and there's a risk of laceration and so on. And also very important, we use this chart, for example, to show the patient visual graphic to what to do for the veteran. So day 1 or 2 rest, they go home, then 3-5 they can write computer, they can fly after 1 week, and within 1 month, after 1 month they can start a light exercise, and after 2 months they can do more strenuous exercise. So this is very important. So the recovery, rehabilitation, post-op, also it is very, very, very important. Don't keep the patient to rest for so long. Then I want to share with you, this was a nice paper by the Hernia Med, I believe, in which they analyzed the trend in incisional hernia in the last 10 years. And you see that open suture repair remain unchanged, about 10%. Why? I think because still the small umbilical hernia, small incisional hernia, still many people do suture repair. Laparoscopic IPOM from 34% went down to 21%. But this is mostly our European number, German-based database. But it gives you a trend. But the open sublay repair increased from 32 to 41%. So probably some of the people who previously do IPOM for more difficult case do a retromuscular repair. And since 2015, since 5 years, there is an increasing use from 4% to 10% of more retromuscular sublay preparatory repair like ETP in Milos. So there is a tendency, as I say at the beginning, from intraperitoneal mesh placement to extraperitoneal repair. If you look at the open sublay and the IMALOS, you can see how this number is about almost half of the patient, either open or lap or mini open. Is about 50% of the mesh are today placed extraperitoneal. So this is my message. And as you see, during my 20 years experience, there is a lot of evolution and a bit of revolution in laparoscopic ventral network repair. And I'm sure all of you experience the same in your clinical practice. Let me thank IAGES, Professor Ramesh Goel, for the invitation, Ramesh Agarwalla, and all the IAGES officers for the kind invitation. And I thank you very much.
Now we have the second
Thank you very much, David. Thank you very much, David. This has been a very exhaustive and excellent talk. I think this is one of the best talks I have heard about ventral hernia surgery. And you've covered every topic so exhaustively and so well. I don't think I have any questions to ask you regarding the talk. But on a different level, I have a couple of questions for you, David. You are a surgeon par excellence. You are also a teacher and inspiration to a lot of young budding surgeons all across the world. And you are a tremendous leader also. You are leading so many associations, IFSIS, ELSA, Hernia Society, APHS. I just want to know, how do you do it, David? What is the secret of your success?
Thank you, Ramesh. I think it has been a great honor to be part of the IAGES Prime. I'm really honored. Sometimes you are in a certain position you don't realize. You look like a dream. But I believe your words, actually. I believe your words. Maybe one day, sometimes you need to work back and then see what you achieve and why you did it. How I do? I think there is a few considerations that I always have in my life. One is time management, and one is efficiency. So I always say that you have one problem, you solve one problem. You don't solve a problem creating another two problem. That is a way to be partially efficient. So we are surgeons. I saw you performing great surgery in a very clean and skillful. Why? Because if you look at your surgery, it's the same. You do one action, you have one effect. That's why you are fast, you are effective, and you are efficient. I think probably with our profession, we learn the trick to be efficient in a matter that we don't waste our time. Time is limited. We have only 10 hours. You can stretch to 12 hours per day. But I also, on the other side, I am very devoted to family, to my life work. I have a lot of hobby. So I usually dedicate no more than 8 hours per day to my work because I want to have a life after surgery. So that's why I think efficiency is very important. So I dedicate my time, 2 hours, 3 hours, but I very concentrate. And what I do, I want to have an effect. So at the end of the day, I say, what I achieved today, if I haven't achieved anything, I will be upset with myself. If I have achieved something, I will be happy with myself because this is, the results.
Yes, I agree with you, David. One has to have a very nice balance between family and work. It cannot be only work. So if it's only work and you don't have family, your output is never going to be good.
You're a failure.
You're a failure. Moreover, you have to have peace in family to do good work. If you have disturbed family, if you're not putting in time in your family, you can never give in the best which you would like to give. So this is the philosophical David we see.
It's true.
The leader, we've seen David the surgeon, now we see David the philosopher.
I think it's very what you say is important. It's not I think you need to have a philosophy in life, right? I'm Italian, as you know. I'm a great admirer of Asian philosophy, from Tao, from Hindu, from Buddhism, and that the inside of this, I think there is it's more a religion, it's a philosophy of life, right? I think you should teach me. Philosophy of life means accept your life, live it at the fullness, in the best way, do your best, the rest will come.
Yes, that's very true. David, one last question. What message would you give to these young aspiring hernia surgeons? How to go about, how to reach excellence?
Today, I think we need to understand that become a hernia surgeon, I become a hernia surgeon. I used to do everything from chest to liver, upper GI, pancreas. I enjoy my life doing really general surgery because the time was different. It's not so super specialized. At the end of the day, my area narrowed down to few areas that I enjoy to do. And I think probably I embark in hernia because it's very challenging. It's really a challenging surgery, especially when we talk about abdominal wall reconstruction, more complex. So my message is today that don't look at what people think, because still what people think about hernia, they like a Cinderella or the surgeon. No, I think hernia today become a very super specialty area in which you need to become proficient, and you need to become proficient in learning many techniques: open, laparoscopic, robotic, extraperitoneal, intraperitoneal, minimal access, mylos, and so on. I think today is a very challenging area. So you need to dedicate time. You need to learn with humility, be humble, all the trick. You need to consider the disease in the global view. As I say, it's not just a hole to patch, but you need to look at all the surrounded, the tissue, the patient, and everything. So you need to become truly a specialist today in this area, like you are a specialist in upper GI or in bariatric and so on. And it's a very, very challenging disease that still we don't know much about it. So there's also a lot of R&D to do. So the future will be brighter. We will be even bigger and better, I think, for the patient. And if surgeon, everybody as a young surgeon become a specialist, he will have the experience of this new future.
Yes, I agree with you. It is no more a side thing, you could do everything. Now hernia is a herniology. It's a different subject.
It's a science.
Yes, and it's a science, and you need all this. David, thank you very much. I just want to say that you are well liked and you are well known by all the surgeons in India, and you are also a mentor to a lot of them. A lot of people look up to you, and we are really proud to be associated with you, and we are very grateful that you are always at beck and call. Whenever we want you for our programs, you're always there. We've never heard a no from you. So we are very, very grateful to you, and thank you very much. It has been a very, very interesting talk, and it's been very nice interacting with you. Thank you very much, David, and good night.
Thank you, Ramesh. Thank you, Ramesh, and good night to everybody, to all my friends in India. Thanks a lot. Thank you, Karagava. Thank you.
Thank you. I think
Dr. Raman, over to you. Thank you, Dr. Ramesh, for giving such a wonderful program.
So I think it was a very enlightening talk, and I'm pleased to have have two of my close friends in one program. David Lomanto, who is Secretary General of ELSA and IFSIS and a friend of Indian surgical community, today shared his experience on hernia, a complete overview, which to a general surgeon like me has been very enlightening. And the second friend, Ramesh Agarwalla, who is a trustee of IAGES and also president of HSI, has interacted with him. So thank you, Ramesh, for taking time to talk to David. And now we quickly move on to the second component of our program today. We have a very senior person, a mentor, a legend, Dr. M.C. Mishra, Professor M.C. Mishra from Delhi. Professor M.C. Mishra will be introduced by Sandeep later, but briefly speaking, he has been a mentor to a generation of surgeons. And I remember going to attend meetings in All India Institute when he was head of the department, and looking up at him for his balanced talk and overview on topics. So it's really an honor to have Professor Mishra on our program today. And He is being interviewed, and Dr. Sandeep Agarwal, who is also professor at All India Institute, is going to talk to him. Dr. Sandeep Agarwal is also editor of JMAS, our flagship project of IAGES, and we are very happy that he also spared time to talk to him at such late time on a Sunday evening. But typically our legends time starts around 10 o'clock, because so many of them, in thousands, people wait to hear words of wisdom. It's not about a topic, it's how they became successful in their life, what is their philosophy, what are the ethics, and how they foresee surgical community evolving over a period of time. Over to you, Kanagvel.
Thank you, Dr. Aman sir. Thank you, Dr. Ramesh Agarwalla sir, for giving us such a brilliant segment 1 of the IAGES Prime Time. Now, with the permission of the President, Dr. Raman Goel, I'm happy to announce the subsequent program for the coming fortnight. Yet another very interesting, and IAGES Prime Time is evolving more higher and higher. We have none other than Professor Michel Gagnère. Professor Michel Gagnère is going to be talking to us on endocrine minimal invasive surgery. He's going to talk on pancreas, adrenals, thyroid, and parathyroid. That was his choice, and it is a choice of the speaker. IAGES Prime Time believes that's where their excellence in. So he will be speaking to us on these important minimal invasive surgery on endocrine organs. And it is going to be none other than our past president and trustee, Professor Subhash Khanna sir, who's going to have the talk with Dr. Michel. That is going to be segment 1. And segment 2 is yet another very exciting and important and eminent personality of IAGES, none other than our advisor, Professor Pradeep Chaube from Max Hospital, Delhi, our past president and president of many societies across the globe, both in hernia world and the bariatric world, who has been teacher of many teachers. And it is going to be Dr. Deep Goel, who's going to talk to Pradeep Chaube on his vision and views about the career and profession of minimally invasive surgery. So IAGES takes pride in giving this announcement. Now moving on to the segment 2, I take pride in introducing Dr. Sandeep Agarwal. Dr. Sandeep Agarwal is from the All India Institute of Medical Sciences, New Delhi, and he had his surgical residency from the All India Institute, and he's a proud student of Mount Sinai School of Medicine, New York, USA, and the Homerton University, London, UK, as a Commonwealth Fellow, where he got trained in bariatric operations. He is a faculty member for almost now 2.5 decades from 1999, and is currently the Professor of Surgery at All India Institute of Medical Sciences. He is an accomplished bariatric surgeon and developed a robust obesity surgery program at AIIMS, Delhi from the year 2008, which is a public funded institution in country to have such an exclusive program for obesity. Since then, he has crossed more than 1,000 obese patient surgery, and he has set up a dedicated bariatric surgery clinic for comprehensive care of obese patients. He is the faculty in charge of the 2 years minimally invasive bariatric fellowship program at the All India Institute of Medical Sciences. Dr. Agarwal is actively involved in research in the field of obesity, bariatric and metabolic surgery. His research interests include impact of obesity surgeries on non-alcoholic fatty liver disease, obstructive sleep apnea, and type 2 diabetes mellitus. He is also involved in collaborative research at various departments, and he has authored numerous book chapters, and the evidence of he being the editor of the JMAS is the amount of excellence he has put upon. Dr. Sandeep Agarwalla is an active member of several surgical societies, and to mention a few, the Research and Ethics Committee for Postgraduate Research in the All India Institute is the most important one, and he also guides and is part of the selection committee of faculty and students at various government institutions and central institutes, including Postgraduate Institute Chandigarh, the Lady Hardinge Medical College, and he has been setting up and is responsible for the Center of Excellence for Obesity and Bariatric Surgery at the All India Institute of Medical Sciences. Ladies and gentlemen, now I present Dr. Sandeep Agarwal to have the privilege of hosting Professor M.C. Mishra to all of you. Dr. Sandeep Agarwal, over to you.
Good evening, friends, and thank you, Dr. Kanakvel, for a nice introduction. Of course, it's an absolute privilege to be, interviewing my teacher and mentor, Professor M.C. Mishra, whose achievements obviously are so many that it will take me, hours to describe them. And at the outset, I'd also like to thank Dr. Raman Goel, President IAGES, and other trustees for giving me this opportunity. And it's really, I'm so happy to be, talking to Professor Mishra, for whom I have been a student since my residency days. He was the head of department when I was a junior resident. And since then, he is sir to me, not Professor Mishra. So, sir, welcome to IAGS Prime. And good evening, and thanks for sparing your valuable time for at this late hour for this program and enlightening all of us about your wisdom and your knowledge you'll impart to all of us today. To introduce Professor Mishra, I'll just share his CV runs into hundreds of pages, but this is a snapshot of his achievements. It's very difficult to put it in one slide. He is very well known for his almost entire career spent at AIMS. Now, obviously, he's retired and is working as a professor and head of surgery at Sharda University in UP. He's the current chair of ATLS program and co-director of ATLS India. But I think he's very well known for his stint as head HOD surgery AIMS, the chief of trauma center at AIMS, and then the subsequent director of AIMS for 5 years. Besides all his these positions he has achieved, he's a prolific surgeon who has a pioneer in minimal access surgery and has brought minimal access surgery, one of the pioneering surgeons in India to have started minimal access surgery in public sector and spread it all across the country. His an academic career, he's prolific, publishes prolifically. He has more than 200 international publications in index journals and more than 15 national journals. He's been an editor of more than 4 books. He's written 50 chapters in various books. Besides the important appointments I've talked about, he has been a part of various national and international committees, the Government of India committees, various selection committees. He's been an examiner to various medical colleges. He's been awarded honorary fellowship of the Royal College of Surgeons of Edinburgh and Glasgow. He's a fellow of American College of Surgeons. He's been awarded the prestigious BC Roy National Award for being, a very dedicated teacher for his contribution to teaching in 1996. He's a member of the French Academy of Medicine. And he's been a president of so many national and international societies that is difficult to enumerate it here. But on a more personal note, I think Dr. Professor Mishra is a surgeon par excellence who's pioneered MIS, who has built the MIS department and MIS field in AIMS and elsewhere right from the scratch. He's an amazing administrator and a versatile leader in every aspect of the world. You have to believe me how his decision making is so quick, and he wastes little time in trivia. He would, he's carrying out multiple tasks, taking very major decisions for various, aspects of the hospital, and yet he devotes equal time to everybody. He's a wonderful human being, but I think at topmost is passion about knowledge, not only acquiring knowledge, but imparting knowledge at every possible moment. And for me, he's been a mentor and a role model since I was a junior resident. I remember when I was a final year junior resident, I submitted my thesis. He was the youngest HOD that time, probably. When I submitted my thesis to him, next day I got the whole thesis was checked. I saw first few pages being totally slashed, and I was a bit worried. But then when I visited him, he explained me everything, and he was very appreciative of the work done. And the next memory I have initially of him was when I was in New York, and our teaching sessions would start at 6:30. And although he was on a holiday, he would come at 6:30 sharp to my house, and we'll both go together and attend those meetings. And everyone in my department, in the department Mount Sinai, was so impressed that, your chairman is so dynamic and so knowledgeable. And it was really proud to be, having him as a head of department that time. He also has been very has helped start bariatric surgery initial. A lot of cases we operated together, and he was always there to help me and guide me. He's a person who's a man on mission. He was never ever be idle. Even on every weekend, he's traveling, operating in various workshops, giving lectures, and yet he's a family man. He will take care of. He has a perfect family life, and he would be very very warm towards my family and anybody who's come across him as a person. So I think I can go on and on. Evening you will find him in the gym. So as Dr. Lomanto said, you have to have work-life balance. He would be like in the gym at 6 o'clock, going there for 1.5 hours, and a very like an absolute youngster. So he was a very 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 motivating person in all respects. So it's again a pleasure to have Professor Mishra to you. I present to you, so welcome, sir. So I'll begin by having your thoughts on an early. How did you plan to be a surgeon? When did you start thinking about surgery as a career?
Okay, Sandeep, thank you so much for such a wonderful introduction. Naturally, our association has been very long. Let me thank at the outset Dr. Raman Goel and Dr. Ramesh Agarwalla and Dr. Kannagwell for hosting me and inviting me for this session. I'm sure I'm going to enjoy interacting with you. I am founder member of Indian Association of Gastrointestinal Endo Surgeons. I am founder member of AMASI. I am founder member of CELSI. So I am associated with all three endoscopic societies. What I believe that they are complementary to each other. They are not opposed to each other with the objective of pushing the boundaries for minimal access surgery in India. And I must say that India has done well in minimal access surgery, much better than many other developed countries as regards expertise in India, and surgeons have done. So if I may start by what you asked, how I got into surgery. See, I did my house job under Professor H.S. Asopa. I think some of you might have heard his name. He was also president of Association Surgeons of India. So he came as I was an undergraduate at MLB Medical College, Jhansi. It was a new medical college established in 1968. And 3 batches were admitted in Meerut along with LLRM Medical College. And then in 1970, I got admission into MBBS. And then we were transferred to Jhansi, and Dr. Asopa joined there as HOD of surgery. He was also very young at that time, maybe 41 or 42 years of age. And he was a leading surgeon at that time in UP and in India. His work on hypospadias, everybody knows. It is mentioned in Campbell Urology. And he was really a remarkable surgeon of that era, where he would do neurosurgery, he would do urology, he would do pediatric surgery, he would do plastic surgery, he would do general surgery, GI surgery. And I witnessed him having done a Whipple's resection in Jhansi in 1973 as an undergraduate student. So you can imagine his versatility. And he was a fantastic surgeon. Hernia he would do at the same ease and efficiency. Very soft spoken. I never saw him getting annoyed on anyone. Once I remember that principal of that medical college came about 8:15 in the morning, and he checked the attendance register, and we would go straight to the ward. We will never go and sign the register. So he questioned that why there are no signatures. So he defended that the boys are working in the ward, so they don't come here to sign. So he was the teacher, surgical teacher to us. And then how I got admission into MS. Dr. Asopa went to Allahabad for a exam, MBBS exam or MS exam, I don't know. But he came back and he gave me a letter, PG admission today and PG admission in 1976 or 77. So that was 78, because Jhansi didn't have post-graduation at that time, because we were a new medical college. Our MBBS degree was just recognized. So he gave me a letter, a small letter, to the HOD of Allahabad Medical College, and at that time, on the basis of MBBS marks, you would get admission into post-graduation. So in Allahabad, I was on the top of the list based on my undergraduate marks, and I got admission there. Naturally, I didn't get a job because I was an outsider for Allahabad, so there was no question of any registrar or a demonstrator job. So for some time, I didn't get paid. But then UP government announced some scholarship for PG students, so that was 450 rupees, and we started getting. And that's how I completed my MS in 1979, and then returned to Jhansi for registrar job for 5.5 months. And then there was an advertisement for AIMS. And in Allahabad also, we had very wonderful teachers, Professor Naithani, Professor Tailiani, very renowned surgeons of that era.
So basically, those renowned surgeons who motivated you to take up surgery, and then you joined AIMS since that time, and you've been had a absolute long, almost more than half your life at AIMS. So tell us about your initial experience at AIMS and who were your role models that time. And
see, at AIMS at that time, Professor Atam Prakash had a big name. I don't know whether you ever saw him. Did you have opportunity to see him?
No, I didn't.
So he was a very renowned surgeon to the President of India. He had already received Padma Shri at that time. He was just going to be awarded Padma Bhushan. Very big name. And he used to come as examiner in Allahabad and Kanpur. And so naturally he had a lot of aura at that time, and somewhere in the back of my mind I was really thinking to work under him. And when I applied for senior residency post, and you know at that time senior resident positions were very, very few, very competitive. They are not like today that people get very easily. So there were at that time 13 posts of senior residents only. 8 in the department and then 5 emergency and Ballabgarh. So I got the appointment letter, and naturally that was the turning point of my career in surgery. I came to institute and I spent 1 year full in emergency, as at that time you would not get ward posting immediately. So first thing you would be posted in emergency, casualty at that time it was known. And then after 1 year, I was moved to surgery unit 1. Fortunately, it was Professor Atam Prakash's unit. But you know, he was also a very high profile surgeon, and he was a part of International College of Surgeons, moving on international arena. And so he was away when I joined the unit. Professor L.K. Sharma was the unit head for all practical purposes. So that was July 1981. I spent 3 months in Ballabgarh, and then.
When did your interest in minimal access surgery? When did it spark off that interest?
But let me just mention about Dr. Atam Prakash. He was again a very tremendous, motivating person. Sandeep, I have not seen a person like him. He would talk to 4 people at the same time, and none of them will feel neglected. He would talk to all 4 of them. And you know, he was very, you must have heard some stories about him in AIMS, because you have graduated from AIMS, that he was very close to Mrs. Indira Gandhi, he had operated Sanjay Gandhi, and all VIPs would come to him for surgery. And that was 81. September I met him, and then in December he tells me, why don't you go as assistant professor to SKIMS? SKIMS was just established at that time, Sher-e-Kashmir Institute of Medical Sciences. So I said, no sir, I don't want to go there. I have come here to work under you. So he said, okay, Mahesh, my younger brother is also Mahesh, so I'll call you Mahesh. So that's what happened. And in February 1982, we were organizing a international conference of International College of Surgeons, and large number of foreign delegates were coming in that. And that was in February. And on 15th February, I still remember the date, 1982, Dr. Atam Prakash had a heart attack and he died. That was a shock of our life at that time. You can imagine Mrs. Gandhi straight away drove, she was the sitting prime minister at that time, to his residence. And Dr. Dhawan took over after his death, the HOD-ship of the department. And that was something which was a huge setback for all of us at that time. But naturally, life goes on and we moved on. Then I completed my senior residency and in Unit 1. And I didn't have a job at that time when I was completing my senior residency. All of my colleagues at that time, the senior residents, they went, somebody went to Iran, somebody went to Saudi Arabia, Middle East, Gulf, but I said, I am not going to go anywhere. I'll stay back here. So Dr. M.M. Kapoor's unit, there was a research job. So I took up that research job under his unit. That was a WHO project, so I did that. And then came a position of lecturer in surgery under a postpartum program in 1984, April. And that was something which Dr. Dhawan recommended. And we were two individuals, myself and Arun Gupta from UCMS for that. And then Dr. Dhawan recommended me for that position. And then naturally, you know, the journey after that.
So, sir, how did you get into MIS? So, how did it start? Did you get,
MIS was Professor BML Kapoor, who took over HOD-ship after Dr. Dhawan. He was also, he didn't stay as a HOD for a very long time. Dr. Dhawan went to Abu Dhabi, and then Dr. BML Kapoor got the opportunity to head the department. There was a conference in Australia. I don't know which city. Dr. BML Kapoor had gone in that meeting. That was World Congress of Gastroenterology. It was not a surgical meeting. It was a gastroenterology meeting. But there was a lot of talk about laparoscopic cholecystectomy in that. So when he returned in 91, that was somewhere July, August. So he came back and he ordered Store's instruments, because Store's was the only company which was manufacturing instruments at that time. So he ordered Store's instruments. We didn't have a camera, and we didn't have camera for quite some time actually. So first cholecystectomy, as you know, was done by him and Dr. Ajay Kriplani in November 1991. And but Dr. Kapoor, then he took voluntary retirement in December, so I became the head of the Unit 4. Kriplani was in the same unit, and I did my first laparoscopic cholecystectomy, not on camera or monitor, looking through the telescope as TUR. Urologists were doing TUR at that time. So what I would say, the MIS, so there was a surgeon called Mohan Chalappa. I don't know whether you have heard his name. He was from Singapore. Raman must have heard his name. And so he was from Singapore. So he came, there was a conference, a CICD conference in Delhi. So he came in that meeting and he brought a video, VHS video of laparoscopic cholecystectomy. And can you imagine the duration of that video? It was a 15-minute video. Who has patience to see a 15-minute video today? So you can imagine, we borrowed that video from him. So one copy, I took it, one copy Kriplani took it. And before I did my first laparoscopic cholecystectomy without monitor and camera, I looked at that video. That was the training. Previous night, at least 10-15 times, that video I looked at. And then I did that cholecystectomy, which took about 4 hours to do that. I remember the name of the patient was Nathi Devi. So that was the patient. I operated first patient.
So the surgeons of your time were self-learned, who learned the laparoscopic surgery on their own. So what were the challenges, and what did what additional things did you use? I remember you used to make notes on your diary of all the cases you operated, and I remember you always sort of, once you write, you remember what mistakes you made, and you used to teach us that way. You should record all your. But that time it was not so computerized. So tell us, the future surgeons, how they should go about picking up skills, and what are the challenges you faced that time, and how we can learn from them.
Yeah, as you know, that there was no training at that time.
Yeah.
So I went for a conference of International Conference of Emergency Surgery in Lisbon. And then I also took permission from AIMS to visit France and Germany. Strasbourg in France, there was a surgeon called Meyer, some Hollander center. And I corresponded with them, and there was another clinic in Munich where they were doing laparoscopic cholecystectomy at both these places. So there was a young surgeon there who was doing laparoscopic cholecystectomy. So I just went, that was June of 91, I'm talking of. And then I visited both these centers and observed these people doing laparoscopic cholecystectomy. In Germany, the surgeon said we keep the patient for 3-4 days after laparoscopic cholecystectomy, because in Germany they don't want to go home early. So that was something we said, we do it for cosmetic reason, the laparoscopic cholecystectomy. Then the challenges, of course, as you are asking, were that we didn't have camera to begin with. Then we bought the zircon camera, and then we started doing, naturally this was a single chip camera at that time. And then instruments were always a limitation. Institute was not rich at that time. We didn't get as much fund as we get today. Funding situation has improved radically in institute. At that time, very limited funds to the departments. So when I went to the health secretary, I think I operated one of his uncles or brother or somebody. So I went to him, I said, I need some money to buy equipment. So he told me, look, everyone says you keep giving money to AIMS. You don't give it to RML or you don't give it to Safdarjung Hospital. I told him, sir, you give it to them first, then give it to me, if they have asked. Then he told me, yes, they have not asked. I said, I am asking. So he sanctioned somewhere around 18 lakhs of rupees. So I bought some equipment from there, striker equipment, striker camera and all that. So then we started doing, and then first workshop, live operative workshop, I organized on January 1st and 2nd in 1993. Then surgeon called T. Yamakawa from Japan, he had come. So he did one gallbladder, he did one TAPP, and he did one CBD. These 3 operations live he did. And so TAPP somewhat I learned from him to begin with. And lap poly we were doing already. And he also did CBD at that time.
Any ordinary person would have given up, actually, because I think this is what your qualities are, to be a go-getter, to do what you wanted with whatever it takes. And I think we were very lucky that you took over as a head of department at a very early stage and pushed MIS. And I particularly feel myself more lucky because I had just finished my junior residency. And then we probably never faced any shortage of equipment or the vision to promote MIS. So, sir, when you became the HOD, I think one of the main things you brought out was the MIS training center to AIMS, which was one of its own kind. Tell us the story behind it, because it's quite a fascinating thing. That I remember you were in New York with me, and on your way back, probably you went to Tübingen.
That's right. I think 2006.
Yes.
Yeah, that's right. So 1993 we organized that, and then 95 got sent German grant. I think a lot of institutions got that. Under that German grant, they got a lot of stores equipment. So we also at AIMS got almost 2 sets of equipment, endovision, instruments, everything. So we were quite good with the instrumentation at that time. Other institutions also got it, like PGI Chandigarh got it, but they could never start laparoscopic surgery. So that was really a boon for us, the German grant equipment, which lasted for quite some time, as you would know. And then naturally, I then went out for some time to Abu Dhabi in between. Professor Dhawan was there and he called me, so I spent some time there. And I returned in 2002 and 2003, and when Dr. Mehta also was there. So this was June of July or June, I think it was June when I was in New York, and then July I was in this place called Tübingen, Tübingen, where this one of the gynecologists had invited Renu, and we were going to, and so he organized meetings with Professor Bius, who was leading this minimally invasive surgery training center at University of Tübingen. And that gynecologist arranged one meeting with Professor Bius and one meeting visit to Professor Bittner's operation theater in Stuttgart. Stuttgart was closed from there. So I was discussing with Professor Bius, and he was a very passionate and very innovative surgeon. He was a real, you know that he developed those instrumentation for a transanal microendoscopic surgery long back in early 80s. So he was developing a lot of instruments at that time, transvaginal cholecystectomy equipment. So we worked with him, and we were just discussing the problem of training. So he had a training center at University of Tübingen. So he said, why don't you go and have a look of that training center? So I went there. The training of this TM was going on there. On the same endo trainer as you have seen in our training center, they were doing the laparoscopic surgery also, training as we do in AIMS. So I saw that and I thought this is something which we need and we want that. So I asked him how can we have it at AIMS. So they had established one training center at Ghana, and one in China somewhere. So he picked up the phone and spoke to someone in Richard Wolf, because he was on the board of Richard Wolf. And he said, we need to establish one training center at this institution in Delhi. So that's how it came about. And this was July 2006 and 2007. We had the training center established. I think Dr. Venugopal was the director. So he signed all the papers, and all those custom checks, etc. happened. And we did our first training program end of March 2007. So that was something huge. Almost 500,000 euro worth of equipment came with that, and they were refurbishing. Richard Wolf was refurbishing that equipment.
So just a brief thing about it. You're passionate about teaching. I remember you would be traveling throughout the country to operate in the workshops, attend all the CCR, CGRs, or whether it's related to surgery or not. You would be taking part in every possible educational activity. So how did it come about? Did you have an inbuilt passion for teaching, or did you have a role model or somebody did it? How did the passion for teaching, which is there, just talk us something about it.
Yeah, but I think
we all need to be teachers, but I think you were a level beyond what one would expect from a surgeon.
I think a lot of us did that in those days. Dr. Chaube did it, Dr. Surendra Ugale did it, quite a large number of training programs. He would go to Northeast. So we all, whosoever could get hold of someone, he would invite. And what we would do, I remember, we operated 40 gallbladders in Guwahati over 3 days. And what we did, and that model I still talk about, that's a preceptorship-proctorship model, basically. So the surgeon who invited me, he assisted me in first day in 10 gallbladders. He held the camera with me. The next day, I held the camera for that surgeon, and he would do. And if he had difficulty, then I would take over. And third day, I would stand out, and he would do it with his own team. So that was something I found. We got this opportunity with the gallbladder, since gallbladder disease was so common in North and Northeast India, that gave the opportunity to surgeons to teach and to surgeons to learn. I think that was something which happened with many surgeons in India. And that's how the laparoscopic cholecystectomy actually spread very fast, very rapid in particularly in North and Northeast India, because the gallbladder stone disease is so common in North India.
So then came the BC Roy Award. What did it mean to you? Because in government sector, these are the things which sort of keep you motivated. And obviously, it was a very deserved award. Could you say something about that?
Yeah, this was a very peculiar thing happened. This was naturally, it was a significant award. This award was given out by the President of India. But my mother was very sick that day. And I was in two minds whether I should go and receive this award or not. That was something, and you can see that I am not smiling. So I lost my mother, I think the same day or the next day after the award. But maybe she was alive only for that award. That I still remember. One of our very close family friends, they were there and they convinced me that you should go and receive it. Mataji will feel very satisfied and happy about it. So naturally, it was I think, timely award for the work which we had done, the development of minimal access surgery at All India Institute, because that was the first public funded institution to have established the minimal access surgery.
How did the interest in trauma came, sir? Then you became the chief of trauma center. In fact, you sort of brought it up into a national level facility with all the world-class care. I remember you when you were in New York, you were on a holiday, even then you were visiting all the trauma hospitals. I could see the passion in you to develop a similar service in India. So how did its passion in trauma care came?
Yeah, my trauma, somehow I got interested in 1988 when I applied for Commonwealth Fellowship, and laparoscopy was not there at that time. In 1988, laparoscopy was not on the scene. A lot of people were in oncology, doing a lot of cancer surgery, and I was also doing esophagus and all other Whipples, etc. But somehow trauma, because at that time, Sandeep, 88, we were losing almost 60,000 young lives every year on our roads. So that is the only difference. Today we lose about 200,000 lives on our roads. So that is the only difference which has made. So everybody was asking even at that time, what is this trauma? Why are you going in trauma? So what I felt that was important and necessary, and AIIMS had planned a trauma center to come up even at that time. If you remember, Dr. Prakash Chandra, who was the head of orthopedics, had conceived the trauma center. But then it could not take off because the funding again was an issue. Initially, it was supposed to be a 500-bedded facility, then 250, and then it was sanctioned about 38 crores of rupees. So construction really began much later than that. And then that trauma center project was almost going to Delhi government from AIIMS. So I then again, the same health secretary was there and I met him. I said, sir, this is not right. Delhi government cannot run their own hospitals. How are you giving the trauma center to them? Somehow we brought it back.
Sir, I remember being a chief of trauma center, head of department of surgery, and you were leading so many programs. I remember I was just amazed. Like there'll be conference in trauma center, there'll be a conference here. You'll also be, helping us with bariatric surgery conferences. So how did you go about it? Can I tell us? Because as a person, I find it absolutely amazing how you could be at every place and then motivate people to be leaders in their field and as well as guide them through it, and yet be there all the time at so many places.
This is Sandeep. I think this is we all need to learn and we all need to practice this. What we do at home with our children, build a team. And it is the team which does basically you have to be a good team builder. And if you have a good team, because you can't do it, you can go to some distance, but you cannot go very far. So if you build a team and trust people, put trust in the people, give responsibility, I think that is something which I consider is the most important to run, whether it's the home, whether it's your driver of the car. You have to give him responsibility, or your children, what they want to do. You have to give them a space to do it. And that is something which happened at Trauma Center also, although that responsibility I did ask Dr. Venugopal that, sir, if you think appropriate, I would like to take that responsibility, because that was not being made functional for quite some time, because 2005 construction stopped, then faculty was recruited, nurses were recruited for Trauma Center. So I think I would say the team building is very, very important, and have trust in your team, give responsibility, give them a space to work, and they'll do wonders for you. And you have done wonders. You have established bariatric program. Virinder Bansal has established renal transplant program, minimal access program. The Trauma Center has done so well that in a very short span of time, we got so much known in the country and overseas. So I think that is something which I would say that we have to believe in our people around us, and don't feel that they are in any way, you are in competition with them. They are your like children. So you have to give them the space to grow. I think that is something which we all have to.
I think that's very well said, sir. As a leader, one must grow more leaders, and that's the job of a true leader. But the other thing, sir, I found amazing in you was the quick decision making. Just now, Dr. Lomanto said, when you're trying to solve a problem, don't create two more. So I think the same quality I found in you was a quick decision making. You would not really bother about smaller things.
Yeah, if you do that,
sort of thought minor from major things, because that's something some a lot of people are not able to do.
Yeah, even today I was discussing the same thing with somebody, that don't get into certain things which will hamper your growth. We know the problems, but we don't have to run out, chase these small problems. They'll get sorted out themselves. We have to look at the bigger picture every time. So that's how I could initiate so many projects, expansion programs for AIIMS, almost worth rupees 10,000 by the time I left. And you know, some of the programs have gone back in time, although they'll be completed, but they'll completed a little bit later. You see the underground tunnel connecting AIIMS and Trauma Center, helipad at the Trauma Center, and all this Masjid Mode expansion, the hostels, the NCI. So almost at one point of time, we calculated there were almost 10,000 crore worth of projects, including this NCI, which is 2,035 crore project, largest healthcare project in India, in independent India, since independence.
Well, that's what I wanted to ask you, because a lot of things got completed when you took over as a director. So many things we could just, been hearing for so many years. Just like even as simple as, on operate a new cafeteria upstairs or a new cafeteria here or a surgical block. They took off, and, they were being pushed very fast, thanks to your decision making. And not only that, a lot of courses. So what MCH courses and fellowship courses, because I think there's a dearth of training opportunities in India, formal training opportunities. I think your initiative in that direction, just talk us through that, sir.
No, I think if you keep your vision and your vision horizon very broad, and think, my institute was not Department of Surgery. It was all departments. So first thing I told Dr. Chandralekha, if you remember, Madam sent the proposal for DM critical care. We are lagging behind. And there are two areas where we lag behind from private sector, because it was the need of the hour. Emergency medicine development, specialty of emergency medicine, and critical care specialty. It grew in private sector in leaps and bounds, but academic institutions were refusing to take that. So that is something, and it was needed. See, okay, when I joined in 1980, there was no concept of critical care at that time. We had post-op care a little bit, and surgical residents will sit with the patient. But critical care has evolved over a period of time as a very important specialty for the care of our sick patients. Similarly, emergency medicine specialty. Very late it came about in AIIMS. Of course, still, I would say in the country it was soon, because 2009 was the first department created in Ahmedabad. in 2011 we started emergency medicine, but then there were need for further training in various subspecialties of various specialties, and like surgical oncology MCH was pending for so many years and was not getting through. So that was, of course, before even I took over as director. So that I was made chairman of that committee under Dean's committee to recommend MCH in surgical oncology. So we did that. Like DM in pediatric nephrology was pending for 9 years. And for some reason or the other, they would not let it start. So I think we had very heated debates on certain programs, as you would have witnessed some of them in staff council meeting. But then we could prevail because we were not working for our own goal or our own gain. This was for larger capacity building for the nation. So I think if you work towards capacity building for the nation and in larger interest, I think then you succeed in doing so many things, like computerization, for example. In AIMS, computerization could not happen. We saw computers were put in the wards, one taken away, and we could not have a good HIS system installed. So all those things, and so there has to be push from the leader. And that is where the role of director comes in, because he needs to have a vision. If the director doesn't have a vision and he only occupies the chair to pass his time, time will pass. They will pass 5 years, it will pass 10 years. Like you see Mr. Modi, how he works, 18 hours a day. So that's how he is able to carry on so much. But not that he does everything, but you have to give the opportunity to people. And good thing about AIMS is I still believe firmly faculty wants to work.
Yeah.
Large number of faculty members want to work. They want to do good work, good research, good clinical work. So that is why I used to tell everyone, look, if you have not asked anything, that is your problem. If you have asked something and we have not given to you, then you can blame the administration. And that is something is very, very important. And you see, funding situation was so much better now in recent times that department actually were sometimes not able to use the funds.
So then I remember, even as a director, you would be operating very actively, and then at 6:30, we'll find you in the gym. So what is the secret of all that, managing such a, complex administrative work along with operating room schedule, and then taking care of your personal fitness and health? So what lessons do you want to give us on how do you manage that? So all of us keep complaining about the time.
That's right. I think, but surgeons need to learn much more. Surgery often is stressful, but I will say sometimes it is stressful, but most of the time it's enjoyable. You enjoy surgery. You are passionate about surgery. That's why you are a surgeon. Similarly, to de-stress yourself, you do need to do some kind of exercise, some kind of a physical exercise, walk or treadmill or whatever you want to do, swimming you want to do, because I think that is where your bodily health also and the mental health also has to be quite stable. As a physician, as a surgeon, as a medical professional, as an administrator, and then you have to take things in right perspective. So I think this is what today we talk about, that only 3 things in life that you find time, balance out that thing, because excess of anything is bad in life. That we know. So balance it out, and the exercise is extremely, extremely important for everyone. And that keeps you going. And even today, I complete my whatever daily routine. I have fixed a target and I would complete it.
So you had a very fulfilling life as a surgeon, as an administrator. Tell us, you have any unfulfilled dreams which you wished you could have done, as well as something about a family life, how the family support was there to help you. I know you have a very, ma'am, she's a very accomplished gynecologist and 2 lovely sons who are well settled in US. So just tell us about, some unfulfilled, goals which are close to your heart and a role with your family?
Actually, now we are moving into that phase where desires are not there now.
No, I know. But as a director, or let's say as a person who you have anything.
I miss the whole environment at AIMS, which we could do so much. There are limitations in private work, which I have experienced now over last 3 years, close to 3.5 years. There are very many limitations because when you are at such institutions, you actually can contribute much more in terms of many other dimensions, and that you can influence, you can inspire people, and you may not know, everybody may not tell you, but when they meet sometimes and tell things, and then ATLS has been my very satisfying journey. So now I actually devote my time, much more my time in ATLS. And we have now 20 sites, and because of COVID, naturally, there was some stop of new sites. So we held a hybrid instructor course on 3rd and 4th November. And so I think that has been really very, very gratifying, satisfying. We have trained almost 8,000 doctors in ATLS. We have held 500, close to 500 student courses, almost 60 instructor courses. And ATLS has so much bonding between the faculty and students. This I could never imagine, actually. Recently, we were invited to share our experience in all level trauma conference which was organized in Riyadh, 7th, 8th November. So we shared our experience. There was a region meeting, 20th, 21st, in a virtual meeting from Hong Kong. So I think that it has been a really very, very absorbing and satisfying journey. What you found, asked that what I want to do, and I am not able to do that much, is pushing laparoendoscopic groin hernia surgery, which is still a lot of surgeons are not able to do, and they are not able to transform from open to laparoscopic groin hernia. Like gallbladder, everyone does it, but groin hernia somehow surgeons find a little bit difficult to graduate from lap poly, and because they find open is so easy, Lichtenstein's repair, open mesh repair. So I think that is one area where I still feel like I went to Jaipur, I got the program established there of groin hernia. They were not doing it. So after I went, so they started at least doing both TEP, TAPP, and also ventral hernia. So I think that is something which I still want to do, devote some time. And today only I have recorded one lecture, half-an-hour lecture. There is going to be a virtual meeting on 17th, 18th December, organized by China, our friends in China, and Professor Bittner. This is International Endo Hernia Society. So I recorded my talk and sent it with video. So they say they can't open it. So they recorded it like we are doing this now on Zoom. So we did a Zoom talk in the morning for half an hour, and they recorded it. So, and surprisingly, our first batch of surgeons for hernia training was from China in 2008. So that is something I still want to do for no charge, free training for teaching groin hernia. That is something I still want to do.
So what is your message to the young aspiring surgeons, surgeon leaders, the various administrators? What is you would want to tell us from your experiences of your life? And you yourself are a role model, and just working with you has made us a much better person. But for others who have not been fortunate enough to be in touch with you directly, what would be your advice to them?
Have passion, like what people I think attribute this quote to President Kalam. late President Kalam, that you should dream in day, and daydreams and realize them. So passion has to be on the top. Positive approach, build team, then you will go very far, and it will be a very, very satisfying journey. Don't think your colleagues are your competitor. Think them complementary, give them opportunity. Everybody has space to work on this earth. So I think have a positive mindset. I never worked at AIMS with a negative mindset, and I didn't want people with negative mind. Even if somebody came with a problem, I said, give me the solution also along with that. We'll implement it. So I think that is something. It's very easy to criticize anyone, to find fault. The faults are there. I always say, is your everything okay at home? Ideal? No, it is not. So don't look for ideal. Keep doing and keep contributing. Whatever is small we can contribute. Life is limited. It's not unlimited life. So that is something we need to realize. As much one can do, one should do, and take people along. I think that is the bottom line. Your residents who work hard, they need appreciation, they need a pat on the back. Of course, when they are not doing something right, you have to tell them. Tell them in confidence, tell them when take them in your office, not publicly reprimand anyone. Like what we call in instructor course in ATLS, it is critiquing, and it is not criticism. Critiquing is healthy. It will bring out both positives and negatives out of you. And first say the positives, and then tell them what points of improvement can be there. I think that is something which we have learned from instructor courses in our ATLS program, and that we can apply, and how interactive discussions, how interactive teaching can take place. So one should enjoy. I think passion and enjoy what you do, so that then you will not complain. And that's why surgeons are different than anybody else, because if there is a patient, you will not ask at 2 o'clock in the morning, why are you calling me? Physicians may not take their call also. So that is something. We surgeons are different than others.
Thank you so much, sir. That's very well said, and you always walk the talk. And it's an amazing, talking to you, and we learned so much from you. And thank you very much again for sparing your valuable time and being such a role model for all of us. So, ladies and gentlemen, I think we had Professor Mishra, the most dynamic leader and a surgeon I've come across, who has mentored thousands of laparoscopic surgeons in India, has looked after so many fields while he was at AIMS. I think we were lucky, this nation and AIMS has been lucky to have such a dynamic, versatile person with positive approach. And thank you very much. And I hope all of you enjoyed this conversation, and we learned a few lessons from that. Thank you so much.
Thank you so much, Sandeep. For these days, I sleep around 9:15, 9:30.
Oh, okay.
Because I get up 4 o'clock in the morning and complete my walk before 6 o'clock in the morning.
Okay.
Then I come back, make tea for myself and Renu. I wake her up around 6:45, and I leave for Sharda at 8:30.
Oh.
To be there at 9:45, and then return in the evening at 5 o'clock. So, but I enjoyed talking to you, and thank you so much, Dr. Raman, Dr. Kangwel, and Dr. Ramesh Agarwal for IAGES giving me this opportunity. And I think all three societies are doing well in India, and all three societies are very vibrant. And all the best to everyone. Keep safe. These are difficult times for all of us, as surgeons more so. These are difficult times, but I'm sure all bad times also go, all good times also go. So nothing is permanent in life. So I think let's hope that COVID situation would improve in 2021. And I wish all of you a very happy new year. And I saw the lights still there behind Raman, and Diwali is still going on. So happy festival greetings to all of you, and take good care of your health. I think that now you must start this early on. Sandeep also goes to gym, so I think it's a good habit, and you should miss it. When you don't go, you should miss it. I think that's the key for health, and balancing out your diet, your some exercise, and then enjoy your work. Then you will not be. I always say, people say we are stressed at work. I said, you don't enjoy your work. Why are you stressed? That means you don't enjoy your work. So there is no reason one should be stressed at work. If you are enjoying your work, there is no reason to be stressful. Thank you. Thank you so much, and good night.
Wishing you all the best. Over to, I think, Dr. Kanak Vail and Dr. Raman.
In fact, thank you, Professor Mishra, sir, Professor Sandeep, sir. In fact, we were discussing this evening, and it is very, very pertinent that one should not get tired during their job, and ensure your fitness matters. Your personal and family life matters. This is the message we have been getting across various eminent persons across in the last 3 months of our program. Across the globe, across the continents, people always is insisting upon work, family, time, life balance. So thank you, sir. I think it is going to inspire a lot of the young surgeons and surgeons in making to take up leadership, innovations, and career in 3 parallel lines together, along carrying upon and picking back on the family and personal fitness levels also. Thank you, sir. Now I would request Dr. Raman to share his part of wisdom before we close the session.
Yeah. So it was, it was so enjoyable to hear somebody who is so grounded and who takes lead in developing a team. And it's almost the same time when we were evolving in our practice, and you getting to know how All India Institute evolved during that time, as Sandeep highlighted, that so many things got completed when you were the director of the institute. So I think this is a learning how one man can change the destiny of generations, of the people around, of the country itself. So I think it was very, very enlightening. And as far as the associations are concerned, sir, I'll tell you, this year we have started having few collaborative programs between the 3 associations. And we are going to host World Congress of Endoscopic Surgery in 2024. The target is that should be we should be representing India and not a particular association. So we should have all the 3 associations, all the leaders of all the associations together to represent India in the World Congress, and we look forward to that. And on behalf of IAGES, I would like to apologize to Renuji that her tea might get delayed tomorrow morning. So please bear with us because we held you back here late today evening. And I would request Honorary Secretary of IAGES, Dr. Ishwar Murthy, a dynamic leader from South India, from Erode, to propose a vote of thanks to Professor Mishra and Professor Sandeep Agarwalla.
Thank you.
Thank you. Thank you, President. Thank you, Kanak Vail. I think we had this prime time really a twin treat for all our IAGES members and also all the surgeons across the globe. Thanks, Dr. Ramesh Agarwalla, our trustee, and also our guest speaker today, Professor David Lomanto, a close friend of IAGES. I think both of us, we know for their crisp, clear statement wherever they go and whenever they speak. I think they proved it once again today. And again, Sandeep, well done. I think you had a very excellent interview with your teacher. We now know he is a teacher's teacher, a true legend of surgery, like a Dronacharya, I would say. He not only saved the destiny of his disciples, I think he is shaping the destiny of the minimal access surgery as a whole. And I really admire your accommodative nature, and we request you to join us in the platform in IAGES when we are hosting along with you the World Congress 2024 song. Thank you for your inspirational speech and interview, and I learned a lot. And I'm really humbled by your openness and ground reality. And friends, I think I need to do a couple of housekeeping announcements to make from the IAGES friend. One, of course, on our online fellowship course, and another regarding our upcoming preparation for our IAGES 2021. We all know we are now, because of the COVID pandemic, we have the flagship course of our FIAGES, EFIAGES, both the laparoscopic and the endoscopic courses are now online, and we are now recruiting the members for our fifth batch. In the meantime, we are also having the advanced laparoscopic course already up running, the online false colorectal and also the hernia and also upper GI. I think next month, people waiting for joining the bariatric and oncology, please bear with us. We are preparing the module and it will be ready by December 20th. I think Sandeep also knows we are all working round the clock. I think we have to get the inspiration from people like Mishra to work more and deliver more to our people, have a thirst for knowledge. I think acquiring the skill, assessing their skill are now going to be the online. That is the way of life. I think COVID taught us a lot of good lessons. That is one thing we know. But still, I think we are now hiding and riding in the virtual world. I think time has come. We have to really go to the good old days. I think that's going to be in 2021, as Mishra said. I think with the vaccine on the horizon, I think things are going to be better and brighter, like the lights in president's behind the screen. I think we are going to see, and I'm very positive on that. I think when you are going to come to Coimbatore in May, I'm sure in 2021 May, we will be all there with academic and gastronomic light, like the way we had in those days, like last year. I think it's going to be in person. We'll be greeting and meeting you without a mask, with our open smiling face. I think that's what we need to have, that intimacy. I think those are equally important. I think it's not just academically, the way we chat with each other, say hello to your friends and meet. I think this is what we are going to look forward. I'm sure it will be a conference with the difference. And until the time, as everyone said, stay safe and stay positive, and Jai Hind. Thank you.
Thank you.
Thank you,
Dr.
Ishwar.
Mishra,
And
just to clarify about this Diwali lights, unlike North India, in Mumbai, the Diwali lights remain till Purnamasi. So
Okay.
Diwali is on Amavasya,
Okay.
and every house will have lights on till Purnamasi. And on Purnamasi, the lights will be taken
That
out.
will be taken out. Okay. So we have also not removed so far.
Yeah.
So we'll do it on Puranmasi.
Same thing in South also, in Tamil Nadu, in Kartike Devam, we call it Devam, and we continue till this full moon days.
Okay. Okay. I think I didn't know that.